NICE issued updated guidelines on management in 2018. Key points are summarized here. Whilst loop diuretics play an important role in managing fluid overload, it should be remembered that no long-term reduction in mortality has been demonstrated for loop diuretics, such as furosemide. The first-line treatment for all patients is both an ACE inhibitor and a beta blocker. Generally, one drug should be started at a time. NICE advised that clinical judgment is used when determining which one to start first. Beta blockers licensed to treat heart failure in the UK include bisoprolol, carvedilol, and nebivolol. ACE inhibitors and beta blockers have no effect on mortality in heart failure with preserved ejection fraction. The standard second-line treatment is an aldosterone antagonist. These are sometimes referred to as mineralocorticoid receptor antagonists. Examples include spironolactone and eplerenone. It should be remembered that both ACE inhibitors, which the patient is likely to already be on, and aldosterone antagonists both cause hyperkalemia. Therefore, potassium should be monitored. There is an increasing role for SGLT2 inhibitors in the management of heart failure with a reduced ejection fraction. These drugs reduce glucose reabsorption and increase urinary glucose excretion. Examples include canagliflozin, dapagliflozin, and empagliflozin. The evidence base shows SGLT2 inhibitors reduced hospitalization secondary to heart failure and cardiovascular death. International guidelines widely recommend their usage. In terms of NICE, a technology appraisal from 2021 support the use of dapagliflozin as an add-on to optimized standard care. Third-line treatment should be initiated by a specialist. Options include ivabradine, sacubitril valsartan, hydralazine in combination with nitrate, digoxin, and cardiac resynchronization therapy. Ivabradine criteria: sinus rhythm and GT, 75 min and a left ventricular fraction, and LT 35%. Sacubitril valsartan criteria: left ventricular fraction and LTO 35%. It is considered in heart failure with reduced ejection fraction who are symptomatic on ACE inhibitors or ARBs. It should be initiated following ACE or ARB washout period. Digoxin has also not been proven to reduce mortality in patients with heart failure. It may, however, improve symptoms due to its inotropic properties. It is strongly indicated if there is coexistent atrial fibrillation. Hydralazine in combination with nitrate may be particularly indicated in Afro-Caribbean patients. Cardiac resynchronization therapy indications include a widened QRS, for example, left bundle branch block, complex on ECG. Other treatments offer annual influenza vaccine, offer one-off pneumococcal vaccine. Adults usually require just one dose, but those with asplenia, splenic dysfunction, or chronic kidney disease need a booster every 5 years.